I think we'll get started. My name is Mitsuo Tomita. Faye Gersh is obviously not here today, our founder and leader. She's been in Amsterdam, I think on her way back now. Maybe she got back this morning or something. The World Right to Die Society, which brings together organizations all over the country, met there in Amsterdam the past several days. Also, Bill Simmons, one of our board members, is also in Amsterdam for that event. So, unfortunately, they're not here, but I'm going to do the welcomes and moderating. Let me tell you a little bit, though, more about Faye. I want to let you know that she got from the World Right to Die organization the award, the Marilyn Sequins Award, for her many years of contributing to the Right to Die movement. So we're very proud that she was recognized for that in Amsterdam. I guess the other thing I'll mention is that Bill Simmons, has been trying to push this word dignicide. We've been trying to figure out how to separate this, whatever we're doing, national death. I recently was reading a blog that was recommending using the term volitional dying. Voluntary, volitional dying. All right. Anyway, we'll be struggling with that, I guess, for a while. I also want to give you a little bit of an update. As you know, June 9th, the California End-of-Life Option Act will go into effect. And in my kind of bumping along with hospices, I should mention, by way of background, I'm a retired family practice physician. And so I still kind of interface with a variety of folks, and also having a hat with Compassion Choices. I've been able to go to Compassion Choices meetings and things of that sort. So with the Compassion Choices hat, I've been talking to and explaining the End-of-Life Option Act to various hospices locally as well as in Orange County. I'll be going up to one next week, again, as I think the various hospices struggle with, as the hospitals and the physicians, with this new law, which will allow physician-aided dying for individuals, as you know, who are mentally competent, California residents, with a expected life expectancy of less than 6 months, who are then able to ingest an overdose of sleeping meds to allow them to die by that mechanism. And I think it should work. I know we were talking, that is, Hemlock was talking about getting volunteers to help with this process. We also understand that Compassion Choices is trying to, and I think this is the right thing to do, push the hospitals, the hospices, and the medical community to adopt physician-aided dying as part of good medical care. So we hope the need for Hemlock volunteers to do that is something that, well, we're just not sure yet. And again, Compassion Choices is planning to have volunteers be involved with that. So we'll keep you guys in touch about that. I know we've solicited money, donations for expanding the Hemlock organization. We'll keep you abreast in terms of how that progresses. We also are always looking for volunteers to help on the board or in various other capacities. So I'll also, in a moment, be passing out some forms, which I appreciate many of you completing, to be volunteers in various capacities. And I'm sorry, again, we've not circled back to several of you to see how we can get you plugged in, but I hope we can do that. Let's see. Okay, so the end of life, the volunteers. Oh, I should mention, as you know, this is our every other month regular meeting here. So 2 months from now, and then we alternate with our film showing. So a month from now, we're going to be showing at the Mission Valley Library, Harold and Maude, an old classic, part of our Right to Die film series. So I hope you'll be at Mission Valley a month from now, and then 2 months from now, our next meeting will address the topic of stroke and end-of-life care. We'll be having a neurology expert from UCSD on faculty. There's a stroke specialist and a hospice physician addressing stroke, which on the one end, again, a lot of tremendous advances in our ability to address stroke, but if things are not so good, what do you do then? Okay, well, today our topic is, again, with this End-of-Life Options Act going into effect, what if you don't qualify? What if you're not able to ingest medications? What if you're not mentally competent to be able to request twice, have a signed form to validate that this is your request? So we're going to start. We have two physicians today, Dr. Bob Uslander and Dr. Sally Hall. I'll have Dr. Uslander come up first, introduce himself a little bit more. He can say, well, why don't you come on, Bob?
I'm on my way. Great, thank you. Thanks, Miss. Hi, everybody.
Hi.
Miss was correct. My name is Dr. Bob Uslander. Most of my patients and their families call me Dr. Bob, or just Bob. I like to keep it pretty informal. I'll tell you a little bit about my background and what and also what I do now, and I will share some about the particular topic that was promoted. But I think it's most important to find out, since we have you in the room, you took your time to come here today, I think it's most important to find out what questions you have. I know that the question and answer part of these meetings is probably where a lot of the meat happens. And I'll introduce the topics, I'll share a little bit about my beliefs, and then we will open it up, I guess, after Dr. Hall speaks as well. So, I've been a physician. I grew up in the Midwest. I escaped the Midwest in 1988, actually 1984, and I went to UCLA Medical School. After finishing medical school, I went back to Chicago and I did a residency in emergency medicine. So I became an emergency physician, and I practiced emergency medicine for about 22 years. In 2013, after a period of gradual transition, I stopped practicing emergency medicine completely, and I moved into practicing palliative care and hospice. So I spent 2 years as the director of palliative care program, and did palliative care in homes. I went into people's homes and provided care for people with complex and terminal illnesses, and I also started doing hospice care as well. And it was really a phenomenal. It happened because I had an epiphany, and it was very clear. I became just one evening, I had what I call a download, and I realized that I was really meant to help people die. And I had an encounter with hospice back in 2001 when a very close friend of mine died of melanoma at the age of 32. And his children were 5, 3, and 1 at the time. And he was a friend, and he had this skin cancer, and a mole had been removed from his back 5 years prior, and the doctor said, everything's fine, you're good. And then 5 years later, he developed a lump in his armpit, and it was biopsied, and it was melanoma, and there really was no effective treatment for him. So as he needed more assistance and care, because he had been a young, healthy man, he didn't really have a doctor, and he just asked if I would help to assist in whatever he needed, and I did. And then as he became weaker and his health was declining, we called in the hospice company. This was in a small town in Northern California. And I'd really never known anything about hospice and never done end-of-life care. I was an ER doc, and all I knew at that point was to try to save people at all costs. And so I had this completely different experience, and the hospice team, they were angels. The nurses, the social workers, the spiritual counselors. I was introduced to a completely different and transformational way of caring for people. And one of the thoughts that kept occurring to me was, why do we have to wait until somebody's terminal to care for them like that? to tell them how much we love them and to give them the best possible care and support. And that stuck with me. That, by the way, that was September 14, 2001, so it was 3 days after 9/11. So it was a pretty dramatic and very emotional time. A couple years later, I started a house call practice for homebound seniors and then a home care company, and I continued moving in that direction, but I finally found my way to doing palliative care and hospice. And then, after a couple years of doing that, I realized that there are still so many gaps. So who knows what palliative care is? Comfort care. Who doesn't understand how palliative care and hospice are different? Very quickly. Hospice is a form of palliative care which is focusing on quality of life and an aggressive management of symptoms as opposed to focusing on the disease process. Hospice is palliative care for people who have a terminal illness and a prognosis of less than 6 months. So palliative care, what people in hospice realize is, well, if you don't have a terminal diagnosis and a doctor can't certify that you have 6 months or less to live, then what then? What do you do? So palliative care was born out of the desire to bring the same philosophy of care to people who aren't clearly terminal, or who don't qualify for hospice, or who frankly don't want hospice, because hospice comes with certain constraints as well. So I was in this world of going into people's homes and focusing on their quality of life and trying and getting to know the patient, the family, their goals, their dreams, and doing everything possible to help to satisfy those, but in a very constrained system, because it was paid for by Medicare and insurance, and there was limitations, as there are with everything. And there were gaps that I saw in hospice. One of the primary gaps was, and who here has had a close experience with somebody on hospice? Okay, not surprised. Looking around the room, I'm not surprised that that's the case. One of the biggest gaps that I saw in hospice care is that there's a very limited role of the physician in that realm. That you have people are close to their physician, the physician's guiding things, and you become very connected with the doctor. Could be an oncologist, a cardiologist, a primary care doctor. And then when you go on hospice, the doctor goes away, and there really is no doctor physically or emotionally connected with the patient and family. So I decided that I really wanted to be able to deliver a much higher level of care and as fully as possible meet the needs of people who are struggling with these complex illnesses and at the end of their life. So I started my own practice, and I started in January. I started a couple months before, but in January that's all I do now. And I go into people's homes, and I take care of them, and I help to fulfill all of the needs of the patients and families. And I have currently 10 patients, and I'll never have more than 15 or 18 patients at one time, because I'm actually probably getting called by a patient now, because they have my phone number, we text, we email, I spend the time that is necessary to be that presence in people's homes to guide the care, whether they're on hospice or not. So as you can imagine, I've dealt with the end-of-life scenario many times. I dealt with it in the emergency room when it was a huge struggle, and I saw many things that were terribly inappropriate and handled very poorly. And then I've dealt with it in the traditional palliative care and hospice world, where things are better, but there's still such a limited ability to address the true needs of the patients and families. And now that I get to do it on a different level, I'm very aware of how critically important it is to have these deep connections with the patients and the families, and what a sad state it is that most people don't have that, and because most people don't. So we need to try to figure out ways to make it more available and more the norm as opposed to the exception. So I certainly have had patients who have requested assistance with ending their life more humanely and compassionately. I, for one, am actually, I'm very happy that we're going to have the ability to do this, at least for a subset of patients, in a few weeks. But not everybody qualifies for that. And even if you qualify, I have to tell you, from what I understand, the medication is fairly expensive. So there's going to continue to be some hurdles that we have to figure out how to overcome. But if you don't have, so the specific topics that I was asked to deal with are the issue of voluntarily stopping eating and drinking. Who's interested in hearing about that? So yeah, okay, so I have to. And the other topic was terminal or palliative sedation. And who's interested in hearing about that? Okay, so about the same. I'm
sorry, I'm quite distracted by what I call the popping of the consonants on that mic. I wonder
Is
if
anyone
you
else?
could just try holding
Can I not use the mic?
just another inch away.
Yeah.
Just another inch away.
You don't need it though.
Does if I talk like this, is there anybody who can't hear me? Let's not use the mic. All right. Thank you for pointing that out. I appreciate it. Want me to start over?
No, you. Go ahead and use that mic. I get another one for him.
Okay. So the issue of voluntarily stop eating and drinking, and I would say for both of these issues, they're very complex, and I can't do them justice in in another 10 minutes. But I do want to. But we'll have time to talk so that there can be specific questions if you have specific issues that have arisen or that you're thinking, you're considering, whatever. I'll be around. We can talk during the question and answer session, and I'm also available to have a conversation with people afterwards. I'll give you my contact information, my cell phone number, my office phone number. To me, it's really critical that these discussions happen. And for those people who feel like it's important to get answers, I'm available. Okay. So I'll tell you a quick story about a voluntarily stop eating and drinking scenario, and it brings a lot of the issues to bear. I gave a talk, this is about 2 years ago, at a local independent living community about palliative care and hospice, what the difference is, where the values and pros and cons are. And after the talk, a woman came up to me and said she wanted to talk about her husband. He had early to moderate dementia. I would say it was probably more early, but he did not want to continue living, not because he was suffering so much or struggling so much, but he knew that within a relatively short period of time, he was not going to be able to make his own decisions. He was still competent enough to make his own decisions, but he didn't know how long that was going to go. So she asked if I could do a consultation and come and meet with them, and I did. And he's a wonderful man. He was 87, but he was incredibly fit. He ran a marathon at 82. So physically, he was a prime specimen. Just a gentle, sweet man. But he started having some memory slips and judgment slips, and the place where he was living started kind of locking. They started restricting him. They wouldn't let him go out in public without somebody being with him. At one point, he was getting kind of despondent about his situation, and he was talking to a psychologist, and he told him that he knows that he lived on the 14th floor, and he knows if he just opens the window and jumps out, it would end it. If he knows when the heavy traffic patterns are. He basically just said he was sharing. And what did they do? Can we just shut that down?
Okay, that's making a noise.
Just turn it off.
It's a hum, it's a buzz.
Turn it off, unplug it,
Off.
unplug it,
Unplug it.
unplug it. Turn it, unplug it.
There you go. Thank you. So he had a conversation with the psychologist, and they actually sent him to a psychiatric unit. They committed him against his will to a psychiatric unit where he had to stay for up to about a week. So he didn't really talk to people about it anymore after that. And when, so I talked with him, and I had to like swear a solemn oath that I was his advocate and I would not be reporting him if he talked about these things. And he essentially said that he was ready to go, and he could not imagine becoming a burden for his family for the years that it could take for him to die a natural death. And because he was so fit and healthy, it could have gone on for quite a long time. I've seen many people who have had advanced Alzheimer's disease and have lived for 10, 15 years. And it's no fun for anybody, right? It's not always horrible, and it's usually not that, and he knew this, it wasn't going to be a problem for him. It was going to be a problem for his wife and his 3 children. So he was doing what was considered the compassionate thing to allow his life to end. And so this is the first time that I'd been in that position. And I clearly wanted to be his advocate, and I understood, and I wanted to help him. So I actually asked if he would take the recommendation of a psychiatrist to go on an antidepressant medication for a couple weeks, see if it made any difference. I was kind of stalling a little bit, and I also wanted to make sure that all his children were on it. His wife was clearly on the same page. I wanted to make sure that each of his children were on the same page, and they were ready for this. And came back and met him again in 2 weeks, and nothing had changed, and his children were all there. We had a meeting, and everyone was on board, and so we essentially began the process, where that Sunday he stopped eating and drinking. Except for Sunday night, he forgot that he had decided to stop eating and drinking and asked for a martini. So he had his martini, and no one denied him. It's up to him, right? That's the cool thing about the voluntary stop eating and drinking. If you change your mind, then you can change your mind. No one's going to make you sign in blood. So we kind of that little hiccup. He started the next day, and I told the family. They asked if he can go on hospice, and I was actually working for a hospice company at the time. I didn't necessarily tell them what was going on because I didn't think it was at that point any of their business. But he couldn't qualify for hospice. There are probably some hospices that would take somebody on at that point, but I think relatively few. So what we had to do was we had to get medication for him. I had to write a prescription for some opiate medication and for some sedative medications, so that if he did get anxious or if he did have discomfort, that it could be administered to him. Unfortunately, in this situation, there was a problem because the place where he lived, there were nurses, there was a wellness staff, and they became a bit of a hindrance. They wanted to control everything. So the medications couldn't be left with the family. They had to be left in the wellness place where the nurses had to be called. So there was some definite challenges with this case. After about 3 days of not eating or drinking, he was very weak and he was mostly bedbound, and we were able to get him on hospice at that point. And he lived for another week, so he lived about 10 days. And it was a challenge, it was a struggle. Because we couldn't do it we couldn't medicate him as well and frequently and aggressively as we would have liked to because of the hindrance. So if he was at home and he had the support of his family, we would have been able to make this a very beautiful, peaceful transition. It was effective, and he ultimately got what he desired, and his family. I continue to be very good friends with his wife, and it turned out beautifully. But it brought up a lot of different unique challenges that come up in that setting. So the most important thing, when I talk about voluntary stop eating and drinking, the most important thing is the communication. Right? There has to be communication that is done so sensitively and well with the family members and the people the people who are involved. Excuse me for a second.
have this Dr. Ulander's speech interrupted. He was right at an interesting spot, but I'm glad he's available. I'm a psychiatrist, so I don't think I'd be a whole lot of help in this situation. Okay. I was going to speak at the end because I belong to an organization called Final Exit Network, where we work with the people who do not qualify for the states that have the law, the right to die, as in California now, fortunately.
What's your name?
I'm sorry, Sally Hall. I will give you a little bit background about me. I am a native San Diegan. I got a master's in social work and worked in social work for a number of years, and then went on to medical school and specialized in psychiatry and child psychiatry, and went through psychoanalytic training, and many years later I finally started practice here in San Diego. I am retired now as of about a year. And I got involved in the Right to Die movement, I'd say 10, 15 years ago. I first belonged to Compassionate Choices, which I think a lot of you know about. And I was really motivated by personal issues. My father had Alzheimer's, and he was one of 8, and I think 6 of the 8 had Alzheimer's. So I witnessed that kind of horrible ending, and vowed that was not something I wanted to go through. So that was part of my motivation to get involved. And I worked with Compassionate Choices for a number of years, and then I got involved with Final Exit Network. Now, I spoke here, I think, within the last year. How many people heard me speak? So most of you know about Final Exit Network. How many people don't really know that much about it? Well, quite a few of you. So those of you that know, I'll try to be brief. As I said earlier, we work with people who do not qualify for the laws that a few states have, and that's a large number of people throughout the United States. I'm one of 3 people in California that is a final exit guide, and so we can be quite busy, as California is a big state and there's only 3 of us here. I also will go to Arizona, all of the western states if necessary. And the way we work is let's say that you, like today, one of the reasons I was kind of late is I was talking with a 48-year-old man who was in a robbery 30 years ago. Very young man, and was paralyzed from the neck down. And he is becoming more and more incapacitated, is not eligible for hospice or any of the laws that California now has. So he's applying to our organization to see what we might offer him. And he is losing a lot of his strength, so he has a window of opportunity that he has to act if he wants to use our services. So what he does is he initially starts with a coordinator, and they talk on the telephone, gather information, and he has to submit medical records that justify that he does have a medical problem that qualifies for our services. Now, we will take people with dementia, chronic pain, what we call old age rational suicide, and illnesses like Parkinson's, ALS, where you can live and live and live, and you don't reach that 6-month window. So he submits his information, an interviewer will call and take more information from him over the phone, and then all of this material goes to a medical evaluation committee, and I'm a member of that committee. 3 doctors will review all the records independently and decide whether we think this person meets our criteria for service. It has to be unanimous, and if we do unanimously agree, and we have some tough cases. I didn't mention that we also take people who have psychiatric problems. I don't think we've ever accepted anybody because our criteria is very difficult to meet. But we are willing to consider people who have psychiatric difficulties. And then after they qualify, a guide is assigned, a senior guide is assigned to work with that person, which I am, a senior guide. And then I would talk with them, and as I did this man this afternoon. And the first step is we would discuss the different choices that would be available to him. He could stop eating and drinking. He could try to get some medication, which people are trying to get from China, Nembutal. Some people go across the border. And for years and years, we used a helium technique that probably many of you know about. It was a very functional way of ending your life. It took about 30 seconds to become unconscious when you inhaled the helium, and probably within 5 to 10 minutes you were dead. It was completely painless, no suffering, and it can't be detected in the bloodstream. For reasons we don't really know, the people that make the helium have diluted it, so it is no longer lethal. So we were out of business for some time until we came up with another method, and we now have found nitrogen works almost better. The difference between the helium and the nitrogen is much more expensive, like 50-fold. The helium was maybe $50, and to get everything for the nitrogen it's about over $600. So that's one of the things that has changed. So the next step after this initial phone call is the person would decide which method they want to use, and most everybody is using the nitrogen now. I don't think we've had anybody trying anything else because it's so effective. And they have to purchase it. We have all the information about where you can get it online, all the equipment you need. It's quite a bit of equipment. It's a big tank as opposed to the helium, and there's regulators, and we were all rather overwhelmed with this new procedure, but we've adapted, and it's really almost better than the helium, because if you use a regulator and the amount of the nitrogen you get is easier to control. So once they have all the equipment, then I and a colleague, we always work in pairs, would go meet this individual and get to know them, they get to know us. We see what kind of home situation they have. If it's private, it's difficult when people are in living situations that they will not have privacy, or where we feel we are at risk to become identified. And probably many of you know there's been quite a few lawsuits where senior guys have been arrested and gone to jail temporarily and gone through, several years of legal problems. So that's a risk we try to avoid, but we know that it may happen. So after and then another big part of our evaluation is to getting to know family members, children, aunts, uncles, cousins, ex-wives. We want to know, we don't want any surprises. We want to know that this person has their support from all their relatives. You probably also know that in the cases where we've had legal problems have been from relatives who did not know what the plan was and found out later and blamed Final Exit Network for helping to kill this person, and people have been arrested, and it's not a way we want to go. So we're very thorough and very in getting to know family. We like family to come and meet us. We like to have everything out in the open and clear. So once we've accomplished all of that, then we leave it up to the person to decide when they want to take the next step. This gentleman that I'm talking about, he wants to, it's a sad situation. He wants to wait 2 years until he's 50. So I will be meeting him soon, but it'll be several years, and maybe we'll never hear from him. A lot of people, once they have the reassurance that we're available and going to be supportive and going to be with them through the process, they change their minds, and we don't hear from them again. But it's just that relief of knowing that someone will be available if they want to take this step. So when it comes, there's another case next Sunday. I'm actually flying to Arizona. This is more of an emergency case. Somebody we haven't met yet, just talked to on the phone, but it's a gentleman who's got very serious chronic obstructive pulmonary disease, and it's like drowning, suffocating. And so we are going to act quickly to try to help him be relieved of his misery. He's very, very clear about what he wants to do, so a colleague and I are going to go there to Arizona next Sunday, and if everything is acceptable and he decides this is what he wants to do, then we will be there with him and observe and be a caring presence while he takes the steps to use the nitrogen and end his life. I guess that's a good description of the process. Since our colleague isn't back yet, do people have questions about what I've said so far? Yeah.
Yeah, could you go into detail about the stopping eating and drinking? Because I've heard it's an easy way, and if it's an easy way, why would you worry about any other way?
People can choose, in our organization, if that's what they want to do.
Yeah.
It's a long process. There's a movie out, a documentary, I don't know if anybody's had a chance to see it. Our organization showed it a number of times, where a physician actually did take this method, use this method, and the whole thing's filmed. And from my viewpoint, it's fairly easy for him, because he kind of was in a dreamlike state, and you don't feel like you're dying of thirst. But it's hard in the family to be around for 2 weeks or 14, whatever it takes. It's very difficult on the family, but it's totally up to the individual. And most people want to hasten this process, so we do what they want to do. It's totally up to them. Yes?
What would be the cause of death?
Pardon me?
What would be listed as the cause of death on the death certificate for the guy that you're going to...
Well, that's depends on the discovery, and that's a whole nother issue. If somebody's on hospice, it's a very easy, way to go through with this. The person we pick a day when hospice isn't present and go through the process and have their equipment removed so it looks as if they died a natural death. As I said, the nitrogen and the helium are not detectable. So they call the hospice worker, the hospice calls the doctor. Very easy, they're taken to the mortuary, and that's the end of it. If they're not on hospice, it can be trickier. We used to be able to remove the equipment, and depending on their condition, it would also appear as if they died a natural cause. But you never know what the police are going to do. I've had cases where I had a 90-year-old man who was very ill but not on hospice, and he didn't even wait for us to come to be with him. He went ahead on his own and used the helium, and the police came and they roped off the scene and put the yellow tape, and had it a crime scene for almost 24 hours and interrogated his son. Even though the son wasn't even there. And eventually they just decided that there wasn't, this wasn't murder, and they accepted that he had done this on his own. But you don't really know. So if you're on hospice, it's very easy. Otherwise, as I said, this cannot be detected, so if there's no investigation, they cannot find anything in the bloodstream. Yes?
If the gentleman had waited 2 years in your other example, would he be in a worse condition where he might not be able to do what he needs to do to take his life?
That's the problem. We counsel people, particularly with people with dementia. You're going to have a window of opportunity, and if you don't act during that time, we can't help you. You still have to be compos mentis, and you still have to be able to do everything yourself. Turn on the nitrogen, put the hood on, and all the things that it takes. So we can only be there to provide guidance and compassion as they go through this. Yes?
Well, my question is similar to that. I'd like to know, how do you decide,
somebody has a diagnosis of early dementia, and then it can, then first there's mild cognitive decline, and then there's something in the middle, and then there's the, end stages. So does it have to be in the mild cognitive decline stage?
Yeah, well, I wish we all had the answer to that. How many's seen the movie or read the book of Still Alice? Yeah. There's no easy answer, and I think you have to, when my time comes, hopefully I won't get Alzheimer's, but the chances are good that I will err on the side of being conservative. Still Alice, for those of you who don't know, she waited too long, and she had a plan, and she went upstairs to get the medication, and the doorbell rang, and by the time she got upstairs, she forgot what she was up there for. Couldn't take her medication. Yeah.
I want to just say one more thing about that. My son, whose wife, unfortunately, has early stage Alzheimer's at a very young age, saw the movie about Alice, and he interpreted that her inability to take the pills totally different than the way I and all my older friends do. He thought that it was not a bad thing that she failed because she had loving family around her, to take care of her. I had I'm of the idea, I don't want my family to have to go through it, but here's somebody younger who thinks, how nice, the family can continue loving her. Wow.
Well, there's certainly many people that feel that way and, really opposed to having people with dementia take their life because they do get into a kind of la-la land where they don't appear to be suffering. But in our organization, we want to honor a person's wishes, and they have to make the decision when to do it, But we want them to have the kind of passing that they want. And that's what we support. Yes?
I knew of a person who had serious clinical depression. He was a very wealthy man, had all the available, but as I've heard many times recently, there's no medication that can take care of the most serious depression. I don't know about marijuana, but there's no medication that can take care of the most serious depression. He ended up blowing his brains out. But he was 59 years old and a very, very successful man. And I thought to myself, from what you're saying, he had no choice.
Well, you didn't mention electroconvulsive therapy. That can be often very, very effective in that. I remember when I was in medical school, I said I would never give electroshock to anybody, but I had several patients, and I got to be known as the ECT resident.
Well, Mesa Vista does about $400 a month.
Yeah, and there were people going to die. They were going to die because of their depression, and I had no choice. And their family and everybody said after they had the shock therapy, they were better than they ever were before. So it can really do miracles.
Especially senior citizens.
Yeah. But another option I should mention is that there are countries that are less stringent about depression than we are. Holland and Belgium and I believe Switzerland will accept people with a serious depression that cannot be treated. And we will too in our organization. We just haven't. You have to have 20 years of a long documented history of depression, trying every treatment available. But yes, the woman behind it.
Could you guys come in and assist if someone's in the CCRC, the retirement communities with full levels of care?
I've done it, but there was a case in Minnesota, maybe some of you heard in the last couple of years, where the court in Minnesota found the exit guides guilty of assisting in a suicide. And we have always gotten off on the First Amendment, freedom of speech. So this has kind of had a chilling effect on our willingness to help people in that kind of a setting. So we want to be private. We don't want anybody, being able to walk in on us or make us sign in when we come in. So we're really steering away from that now. Yes.
Me?
Yes.
I wanted to address the gentleman in the front who asked about the SED, the voluntary stopping eating and drinking. My mom was 90 and lived with us, and she
did the VSED, and my dad had died 5 months earlier, 6 months earlier with hospice, and I don't think she had an easy time of it. So I think for some people, and then they put my mom on hospice, and we were giving her lots of morphine, but I think she was still in a lot of pain. And my parents were big supporters of compassionate choices over the years, and that's why I got involved with it after they died, because I hated to see my mom dying that way. I mean, I just felt like she shouldn't have had to die that way. And so maybe for some people it's easier, and maybe it was easier for her and it didn't seem like it to me. But I mean, even with the morphine, she was moaning, and I supported her in it, but I almost took her to the hospital at one point because I thought, you know, she is suffering, and she had said, don't take me to a hospital, they'll just bring me back to life and I'll be worse. So I think maybe it's just that it's harder on the family, but it seemed to me that she was really suffering even doing that.
I myself haven't had experience with it, and it's too bad that Dr. Uslander, maybe he'll come back, but
so I think it's not always easy for people, but again, I could be wrong because I'm the family member, not the one doing it.
yes. Whoops.
I also had that experience with someone who was often getting not eating or drinking, and it was as the organs broke down, there was a lot of pain involved, and there was more and more morphine, used, but yeah, there was a lot of pain involved. So
Question over here? Yes.
Yes, I know how you used to be able to get the helium tanks at the party stores.
Right.
So how do you get the equipment that you need and the tanks and everything for nitrogen?
We have a website where you can order it. And so when we have a paper that tells you where to go online and order it on the internet, and it'll be delivered to your home. Everything you need.
Thank you.
Yes.
About you mentioned relatives getting everybody on board so that there are no surprises. How aggressive is the Right to Die movement in trying to find all the relatives that could possibly come forward?
Well, it varies. We would like children, brothers and sisters, if it's a younger person, parents, but we don't dig up some long-lost relative in England or something like that. But, just the kind that we think are realistically might be opposed to it. So, yes.
What percentage of your cases get thwarted or stalled because of one relative objects?
I don't think we've ever analyzed it statistically. I myself, over probably 5 years, have had 5 or 6 cases where I won't go forward with it because I just don't feel safe for myself. I don't want to end up in jail, and it's lots of times there's someone who's very religious in the family and is just totally opposed to anybody taking their life. So we do turn people down, but not that many. Yes.
With the nitrogen, does that use a bag?
Yes.
But when you order it from the website, it comes with the bag already equipped?
No, you have to. It's the same with the helium. You have to make your own bag. So, but it's easy. It's pretty easy. You get a turkey bag from the grocery store and a headband, and yeah.
Do you have an age requirement? In other words, do they have to be of a certain age, over 18 or something?
I believe we have an age requirement of 18. We've never had anybody younger than that, and I don't think we have. I think we'd like to. Belgium now has children can use this means of ending their life. Of course, they have to have several doctors okay it, and the parents have to be supportive, but I believe we have to have adults. Yes?
Is there a cost for your services?
No, absolutely not.
What was the question?
Do we charge for our services? No, we get donations. People often will make donations, but we cannot accept any money. We pay for our own airfare, rental car, hotel when we go. So it's totally free. Yes?
What's the shelf life for nitrogen tanks?
You know, it's kind of new for us, several years at least. I mean, the helium, people, I have my tanks of helium that I can still use, and I've had them for 4 years, and I'm counting on them working. But,
There's a donation page at the back of here for Final Exit Network.
yes.
In case anyone wants.
Yes, back there.
After a diagnosis of Alzheimer's, you say you would be conservative. Can you specify a range of time that you would not wait beyond?
You mean me as the person going to end my life, or me as an exit guide?
No, to end your life.
You know, some dementias are slow, and some are very quick. So we talk to the people, and we have certain kind of guidelines that we recommend, that you follow. That if you finding that you're having kind of blank spaces, you can't remember what you went upstairs to get, it's getting to be time. And as an exit guide, what's so funny? Pardon me? Well, it's a hard thing, but as a guide working with somebody, you begin, you have an awareness of. They're getting to the point. I mean, they call you in the morning and they call you in the afternoon with the same kind of question. And we would be very explicit, saying, I think it's time. You called me 3 times today with the same kind of question. And most people have family members, too, that can be good observers and assist, that the people trust. So...
Are those guidelines written out anywhere, or you guys just kind of sense it?
They're not written out. Okay. No, it's an individual kind of assessment. For the senior guide is responsible for making a decision. I can remember a woman I had in La Jolla that myself and my associate guide, we would go and see her and say, well, we can't do it. She's too out. Then she'd call us back in Vegas. Please come back and see me. And what we require is they can say their name. They want to end their life. They know they have dementia. They want to end it via helium. They can make sentences like that they are very clear in their mind what they want to do, and they can do that over an hour or 2. And since we've known them, they have a written health care directive. Then we'll go ahead and support them, even though they may have some really bad days. But they also have to be, with it enough to know how to turn on the nozzles and put the hood on and make the hood, all that kind of thing, which requires some competence. Yes.
As people age, often their strength in their hands goes. What kind of tasks are necessary to manipulate this?
The only real task for the hand is just to turn the knob, and we. We're leaving?
No, he wants to clean the spot.
Oh, I'm sorry. Well,
So it has to be done just in the
I didn't know what it was specifically. Anyway, a wrench, we often tell them have a wrench available, and that really makes it easy. I've never had anybody not be able to do what they need to do. We test it ahead of time. I mean, in the first meeting, we have them test to see if they can crack open the tank. So we know that they can do it before we're the final meeting. Yes?
How many people order the supplies and don't follow through?
Again, we don't have reliable statistics on that. I'd say easy a third we never hear from again.
That's what they say in Oregon and Washington. People
Yeah.
order the stuff and about a third of them don't never use the supplies.
Never hear from them, yeah. But some people, we don't hear from them several years, and then they call up and, you know, you don't know. We say, shall we shred the case? And, you know, then we hear from them, yes, way in the back.
How long does it typically take from the time someone calls you until you can be there with them?
You know, with this gentleman I'm talking about, that next Sunday we're going to, I'd say it's been 3 weeks. So we can act very fast. Usually the main problem is getting medical records. You know, doctors are not willing to part with those records easily. And people, it sometimes requires people to have to be very aggressive with the doctor and say, you know, these are my records, I have the right to them, and people don't like to do that. And they're also afraid that if the doctor gets suspicious why they want the records, they're going to end up in a psych ward, you know, if they talk too much about it. So that's our main roadblock. But we're ready to, you know, act quickly if somebody needs it. Yeah. Oh, I didn't see you come back in.
I'll come up. I might have answered this already, but can you work with people who are on hospice? I mean,
Oh, sure, we want people to be on hospice.
So how do the hospice agencies typically respond?
We're a secret.
Yeah, that's what I thought. Yeah. So you want them on hospice so they're getting the support and care, but the hospice agency, you make sure they don't know what's going on.
Right. Because we just can't trust what, if we had everybody like you, it would be wonderful, but we can't trust, you know, what they'll do.
Right. Yeah, it's a big, what the hospice agencies are often looking out for patients who are suicidal, right? And making sure that if that's the case, then the medications get secured and everything gets stirred up in that case.
Yeah,
unless you have a
go back over. I didn't sorry.
Unless that's okay. No.
One last question.
Yeah.
I understand that you asked that the people be members of the Final Exit Network. Is that correct?
They have to be a member, yes.
And that's how much for a...
$50 membership. They have to pay that, yeah.
Exit fee.
Yes.
There's resources for Final Exit Network in the back. You can sign up and mail it into for the office, and you can become a member overnight.
Yeah.
Very easy.
Yeah. Okay, one more question, then we'll...
Well, we can just open it up to questions for either of us. Why don't we do that?
Why don't you finish your presentation?
What you were telling us.
Well, actually, yeah, you have a question.
Know what happened? Can we hear the feedback?
What happened where?
In this place?
Oh, just now?
Yes?
This sweet lady she had a little minor GI illness and got lightheaded and passed out.
Okay.
And then came to.
Yes. Okay, so she's okay.
So this is...
She didn't die.
No, she's alive. And this is so here's an interesting scenario. And I'll just share this. I don't think I'm divulging any information I'm not divulging any personal health information or HIPAA violations. But this is a situation where somebody had an incident that occurred and we don't know what caused it. We don't know if it was life-threatening or not, but she's 95 and she did not want to go to the hospital. She did not want an ambulance called and she did not want to go to the hospital. But she lives alone, and every time she would move, she would want to get nauseous and throw up, and so...
Is this her daughter who lives with her?
No, it's a friend. She lives by herself. She's 95. She lives on her own. So, it would put her friend in a precarious position if she said, "I'll take you home," and leave her there by herself. And so what do you do? What do you do?
You do.
We call it, the paramedics came and convinced her to go to the hospital. And she's going to get checked and probably needs to get some medication, maybe hydrated, and I understand that that's not the perfect scenario. In the perfect world, I would take her home and stay with her and figure out how to help her or someone like me. We would get her home where she wants to be. She's worried about finances. She's worried about a lot of things. And of course, anytime you end up going into the hospital, you don't know what's going to happen because the system is not sensitive to your needs. And even though you can sign an AMA against medical advice form in a situation like this, she wouldn't have anyone to come get her and take her home and make sure she's safe. So the system has so many problems, so many holes, and there are folks who are looking at trying to fill some of those holes and gaps, and but bottom line is you need either to be a strong advocate for yourself, or you need somebody in your family who can be a strong advocate for you, or you need to find a professional in the community who will be a strong advocate for you. If you're just leaving it to chance that the system's going to take care of you, you're out of luck.
Do those exist? Are there professional advocates?
Yes. Well, I'm an advocate. I'm a professional. I'm a physician who kind of does care management and advocates for people. There are care managers, nurses, social workers who will work as advocates for you, and some of them are very knowledgeable. I guess one of the downsides to the people to those advocates is they have to have a very strong ability to communicate and be very persistent, because to try to get, sometimes you need to be advocating to the physicians if you're still seeking medical care and wanting to get appropriate care. A physician, your physician, a physician has to be on your team. And if you have the advocates, sometimes physicians, you might be shocked to hear this, but they can be difficult to get a hold of. They're not always looking, they don't always kind of put themselves out there to try to do the right thing for the patients. The system is, and I'm very sensitive to how that's all developed and why it happens, and it's sad. It's a sad state of affairs that the medical system is currently in, but the fact is that that's the way it is. So there are professional advocates, care managers that exist.
In your role as an advocate, I imagine it's not covered by Medicare. And if it is not, or even if it is, would it fall under the aegis of some long-term care insurance program?
No, unfortunately no. We've looked at that, and I've actually tried to see if, because in long-term care insurance often will provide for an assessment, a care manager assessment, or ongoing care from a care manager. And I've tried to get my care reimbursed or covered under that. I haven't had many opportunities to try to do that, and maybe if we continue to push for it or move down that path, it would. But as of right now, it's private pay for me. And the reason I do that is because Medicare just won't pay for what I do, unfortunately.
Medicare is about to start covering consultations.
End-of-life consultations, they'll pay $86. And I don't, so I want it to be very clear, I don't just do end-of-life. I take care of people who are dealing with complex and challenging illnesses at any stage. If you have a new diagnosis, I have a patient he's 59, he has hepatocellular cancer, and he's been trying to decide whether to agree to a transplant or do alternative treatment, and so we try to look at all the possible scenarios, kind of bridging the Western and holistic approaches to care. And sometimes it's just 95-year-old ladies with dementia who live by themselves, and their children want them to be appropriately cared for and advocated for, and not have to go to the hospital if they have a fever or fall. They want them to get taken care of wherever they are in their homes. And then it often becomes the end-of-life conversation. But the key, and this brings me back to where I think I might have been left off my talk, the key is the planning. It's the preparation. It's having the conversations and filling out your paperwork and your forms and and not just doing the bare minimum of it, but looking at all the possible scenarios. And there are some new, pretty extensive documents that are being developed, and opportunities to make sure that your wishes are very clearly delineated, because you want, you all know this isn't news to anybody, but you want your wishes to be honored whether you can, in that moment, speak to them or not. You want to make sure that if it's your desire that when you can no longer recognize your loved ones or be aware of where you are, that at that point you do not want anyone forcing you to eat, so that you can have a graceful exit, your documents need to clearly say that. Because if they don't, people are going to think that they're killing you. Like, and even if they think that's what you would want, if it's not documented clearly while you're competent to make those decisions, it's going to create challenges for you.
Could you address that terminal sedation and palliative sedation?
Yeah. So, did you have a question on that real quickly?
No, just with the new right to die law, that people need to be able to administer the medication themselves.
Yes. Yes.
This guy had a question for quite a while.
Oh, I thought he was just sort of exercising and giving his range of motion.
When you get into discussions about hospice, people who've worked there and seen it work very well with many patients, but they still don't realize there might be failures in hospice. Do you have a figure of the failures? I have a figure of 1 out of 20, and I don't think it's very accurate.
What do you mean by failure?
Well,
that they don't die?
They don't keep the patient comfortable as they die.
Sorry.
Simple as that.
Oh, that they're not that they're not able to optimize their comfort and.
Yeah, it's not something you choose yourself.
I'd say 50%.
Oh, I figured.
Yeah, because having been there, and I'm not saying that that means that 50% of people are struggling and suffering continuously or excessively, but I think 50% of the time there are issues and challenges that are where people would say, I would do it differently if I could do it over again.
It's not quite perfect, yeah.
Correct.
Yeah, thank you.
Yeah. And I think a lot of that is because of the expectation going in. Sometimes people are sold the hospice benefit without really understanding all that they get or don't get or may have to give up or may not have access to. So that's part of having an advocate is really also important during that transition when you're choosing to go from more aggressive curative treatment to comfort care or hospice care, because somebody who knows, you need an objective. It helps to have an objective supporter who can make sure that you're getting the true picture.
All that you're entitled to.
And more. And more. Because what happens is hospice allows you to be entitled to certain things, but no one's going to tell you that you can have more. You might have to pay for it. You might have to look for it. But I've taken care of, when I was working on hospice, I took care of multi-millionaires, billionaires whose situation was untenable and struggling, and it was challenging, and they were dissatisfied. But nobody told them they could do better, they could have more. And a lot of that was because it wasn't readily available or accessible. I'm sorry, she had a question there. Yeah.
This is my first meeting of the Hemlock Society.
Me too.
And I would like to know if there's a list of doctors who are interested in this topic and are willing to go along with it. I would like to create a conversation with a doctor while I'm very healthy and let them know what I want and let them know that they are of the mindset that would be willing to suggest this.
We don't have a list, and I don't think we're going to have a list, but I think the polls across the country, and certainly in this state, have shown over the years greater public and professional acceptance of the End-of-Life Options Act. So I think your chances are 50-50 that whatever doctor you're seeing is going to be acceptable to this end-of-life option, mentally competent, request twice, signed paperwork, and be able to ingest this medicine. But we'll see. But I don't think you're going to have that much of a problem.
But I think you're not specifically looking for a doctor who's going to say that they'll support that specifically, right? You're looking for someone who you can talk to and will be open to the conversation.
I would like a good primary care physician who understands what I would want near the end of life.
Do you have a primary care physician?
Yes.
And do you feel like have you tried to have the conversation?
So she's a darling young thing.
You might be surprised if you bring her the right documents. If you do the legwork and get the right documents, and she very well may be open to it.
Yeah.
Don't you feel that it's up to you to choose an advocate and
work with your advocate all the time, all through your health care, and you should be an advocate for your friends and family.
Idea that'd be, yeah, absolutely.
I
Absolutely.
have found this with my family and friends that everyone needs an advocate.
Everyone needs an advocate, and especially if you're in the hospital, if someone goes in the hospital, never leave someone you care about alone in the hospital.
24/7.
Whether if you don't have somebody who's knowledgeable in the family or a friend who's willing to do that, you got to hire somebody. I mean, of course, that means it's different if you don't have it. Sometimes it's a financial thing. If you don't have that, then you need to make sure that you're speaking to the case managers and that you're getting. It doesn't cost any money to have these conversations and let them know that you're really concerned about medical errors and about the issues that can come up when you're in the hospital, not having anyone watching out for you.
And don't be shy.
Yeah, it's critical. It's critical.
Stand right next to or
Ask the nurses what they're giving.
Yes.
Ask them why they're giving it. Ask if they double checked it. I mean, I've had patients who have been in the hospital, and I had a patient who's on methadone for chronic pain management, and she was in one of the finest hospitals in San Diego, and instead of getting 5 milligrams of methadone, she got 50 milligrams of methadone.
Yes.
And it ultimately, she ultimately did okay, but the flurry of activity, being skirted, shooed off to the intensive care unit, all these things, it left her with a pretty significant PTSD and nightmares, and that was like, and that was the best outcome, right? There are so many people. There was just a report that medical errors is the third leading cause of death in the United States, and I think they're probably underestimating because you can't report that on a death certificate.
The right to die laws, Oregon or here. I have friends that feel that when you get the Nembutal, that it's one pill you take, and I'd heard it was multiple pills that you had to open and put in. So
it's multiple capsules that have to be opened and put into a slurry and.
Okay, and give me a figure for multiple capsules.
I don't know.
90.
90 or 100.
Yeah, I was going to say 100.
90 or 100.
Right, 90 or 100. And the experience from Oregon and Washington is, there's this film about how to die in Oregon where I guess someone's opening all these capsules or a family member is. What we wanted to do is try to get the pharmacist to open up those capsules and put them in a bottle and mix it up with apple or strawberry, whatever your favorite flavor is.
But while the individual needs to be able to physically take it, they don't have to be the ones to open the capsules.
Yes.
Can they take it through a straw?
I think so.
Yes.
Why is it so difficult to kill somebody? Don't they have something that would just be done? 90 pills?
They aren't succeeding in executions anymore. They aren't. They cannot get the drugs from Europe.
Let me touch on the terminal palliative sedation.
Thank you.
I'm raising my hand for my husband because he has a
Okay.
score.
Okay.
What if you just have one hand and it doesn't work very well? You make this up.
What if
Talking about for medication or the nitrogen?
But who's going to get it there? Who's going to get it to that point?
I think the most important thing about this is the mental competence, desire. If someone can position it so that you would be able to take it. You don't have to physically be able to, sing without any assistance, get it to your lips and drink it normally. If you have physical disability, if you think about someone with ALS or people who are weak and
Like a missing spinal cord that's been eaten up from a disease.
There you go.
That's where we're at.
So it just means that basically you have to be able to get it, like hold it in the crook of an arm and get your mouth around a big straw or a sippy cup or whatever.
Or for using the nitrogen, I haven't seen anybody who, has modest use of the hand not be able to do it.
Even if it's one hand, so you're not having to hold something with two hands around you or anything?
I mean, you have to put a hood on, but you can do that with...
Because here's, I'm sorry. This has been a 16-year disease battle, and I've been the advocacy. I fought more doctors and nurses and people not cleaning my husband than I care to tell you, okay? I have been through a fight to save our family and keep us alive, and with that half full glass, look at our kids are okay, and everything's okay, and look at we're still here, and we love each other, and we're still, and that has gone on for 16 years, and it's very difficult for me at this point to give up that fight. And he's there, he hurts constantly. Right now he's in excruciating pain, I know that. And so he's hurting so badly now that he's here for this reason today. And when he asked that question about his hand, I'm not going to be, I don't want to be that person that's making that thing accessible to him. My heart can't go there. I can't do that.
But if he's choosing to do it, you're supporting him.
I'll support him because I love him and I want what he wants, but I can't be that person.
You have children?
Yeah,
How old?
and they're 21 and 18 and a half, and they're great. And they'll support him.
He'll get what he needs.
Huh?
He'll get what he needs. But it's understandable that you wouldn't want to be, that you would have that. And
because the thing is that everybody adores him. All of us, we adore him.
I adore him.
And thank you. And he's a great man. He's the best man I've ever known in my entire life, and I'm so lucky that I've been with him for 37 years last Sunday. And that. So in 16 years of our time together, there's been a disease, but I know my kids, you know, they're not even there. They've had 16 years of a disease, so they know that there's been, you know, huge tragedies and things where he almost died several times. So they're like right now not even sure that I don't think they understand the severity where his head's at now. And we gotta have a communication. But anyway, I don't want to take up too much time, but that's just the difficulty of he's there. I'm kind of like, what do you mean? You're still here. We got to keep trying. We got to keep trying. And I know I have to respect his feelings.
I'll give you a card if you want to have a conversation at some point.
And you said you would provide contact information.
I will. I have cards if anybody wants to grab a card. I'm so sorry I missed your talk. Should we catch up?
You come back in. I'm sorry that you're done.
So palliative sedation essentially refers to rendering somebody unconscious in order to alleviate symptoms. And they could be symptoms of pain, any shortness of breath, inability to breathe, and it could also be mental anguish. And there's really three types of palliative sedation that you would look at. One is terminal sedation. If somebody's at end of life, and you're going to render them unconscious, knowing that they will be that way until they die. And you're not necessarily looking to hasten their death. You're just looking to make sure that you have reduced their burden, their suffering, so that death will occur naturally at that time. There's respite sedation, which is when somebody is struggling and they're suffering from symptoms that have been unable to be managed appropriately, and you're doing it in a more of a temporary fashion, where you don't. The intent is not to render them unconscious so that they eventually pass away peacefully, but is to give them a break. Is to reduce the pain and suffering with the expectation that you will hopefully be able to lighten and reverse that sedation at some point to see if they're feeling better. And at that point, and they can go on and you can identify other means of providing comfort and support for them. And then there's the third is really around emergency palliation, which is when somebody has, sometimes it kind of flows into the terminal sedation, but if somebody has an acute event, a catastrophic, traumatic type of event, and the goal is to get them through that event, understanding that it may end up causing them to stop breathing if they get more deeply sedated. So The sedation is typically done, most effectively done with intravenous access, with medications like morphine or Dilaudid opiates, and or benzodiazepines, which are sedatives like Ativan or Versed, the things that are often used for people who are going through procedures, to sedate them for procedures. Sometimes it can be done orally with sublingual morphine or other medications. It's not typically as effective, but if it's a person a lot of times on hospice, at least in the short period, if something happens, an acute episode, they usually don't have IV or subcutaneous under the skin access. So the only means that you often have is giving enough medication orally that can be absorbed through the mucous membranes. I've done a number of sedation episodes. It's actually when it's necessary and you finally get somebody sedated and comfortable, it's a beautiful thing. And everybody starts to breathe much more easily, and then you can create a very peaceful, beautiful, transformative experience. I think one of the things that we tend not to do often enough, unless I didn't see it happening when I was doing traditional hospice, but I certainly do it now, is when there's a situation where there is the possibility of a catastrophic event. For example, somebody who has a head and neck cancer, where they have a tumor that's eroded it's wrapped around blood vessels and potentially could erode into the airways. There's always a possibility that they're always afraid. People are always afraid, the family and the patient, but more the family, that something is going to happen. It's going to hit the fan, and they're going to hemorrhage or they're going to asphyxiate, and it will be a huge struggle and a terrifying situation. And I make sure that there's medication in the home, and enough of it, and it's prepared in a syringe, that if something does happen, that the family or the caregivers or whoever is there is able to get them sedated and administer this medication, so that within 30 seconds to a minute, the situation is under control. And the idea, I go into homes sometimes and I meet with people who are dealing with these things, and it's been a terror, it's been a fear that they live with continuously for months at times. And just taking that fear away sometimes makes all the difference in the world. It almost never needs to be done, but having that knowing that you have that out if your loved one is in that situation and struggling is really significant. So those are the types of that's kind of the palliative terminal sedation. Was there anything else about that you want to cover?
No, I think that's...
Are there any questions?
20 plus years ago, I remember when it was said that oncologists would slowly increase the amount of morphine a person was getting to make them comfortable, and eventually would take their life.
Okay. So that's a form of palliative sedation, right? And they wouldn't typically admit that that's what they were doing.
Right.
It was just being...
It would be clearly something that was at the end stage of whatever it was.
Right.
Well, in respecting time, I want to thank, first of all, let me thank both Dr. Bob and Dr. Sal.